So the next case is a 27-year-old female with low back pain. She's taking a regimen of 6 oxycodone acetaminophen 5/325. And you do a point of care test. So that's that little cup that you have in your office, and it comes up negative. So I'm going to ask Houman to take this, but I'm going to point out several things as we start. Number one, it's a young category of patient, which puts them at a higher risk for addiction. Number two, a nonspecific diagnosis, low back pain. You know how that is. Everybody kind of have discs, even though she's young for that. So what do you do with that?
This is one of the most frequent scenario actually that we get asked about. We see it in our office and we get asked about from primary care point of view. You have mentioned multiple points. The first of all, the young age. The second of all, the high dose of opioids that we're not necessarily advised to use in such a young agent, especially when you don't have a very prominent pathology. And then the point that comes that she's negative for the opioid, and then you're going to use a point of care, which is KM negative. The point of care, we know that it's a very, in my opinion, it's a very unreliable test. The point of care should not be used in a clinical management setting. It has a better role in emergency. It has better role in acute, but in a chronic management, I don't believe the point of care has a role playing in the office. When such a patient get to your office and they become negative for the opioid, first of all, one of the things that we've been talking about is protection of your practice, protection of the public. Protection of the practice, I cannot give a medication for someone who's not taking the medication. To me right now, the first indication, not taking the medication, they have to get a confirmation of the urine drug screen. I have to send the urine for confirmation. The patient refused. There's not much I can do. I have to explain to her why. I have to explain to her that this is part of the treatment. If she refuses to get the confirmation, I will not be able to continue treatment. I will not be able to give her the medications. The scenario that comes that let's say that they agreed to send the confirmation and she is willing to pay for it. What would you do? Would you give her the medications? Would you give a prescription until the confirmation comes back? So the first scenario is that the best approach to it, give her a few days of prescription until she comes back with the confirmation, and then depending on the confirmation. Now the confirmation come whether it's negative or positive. Let's say that the confirmation came back as negative. What would the next step would be? And if it's positive, would you continue to do the same therapy? This is where the role of, in my opinion, a chronic pain management, and this is the role where I think the patient should be referred to a chronic pain management center where the patient could be followed there. But if we get the scenario that the patient came back negative with the confirmation, I believe that the patient should not leave with another prescription coming out of that office.
Other comments?
Why use pill counts in my practice? My practice is, I think, is unusual. I see patients who have addiction only, patients who have pain only, and I'll take care of the patient who has both if he or she is willing to work a program. And I do pill counts. And just as an addictionologist, I know that a lot of the drug deals are done over the weekend. And if I think diversion is part of the problem, which is very hard to pick up, and a negative urine drug test does not indicate diversion, it's just one of the differential diagnoses that you find with a negative urine drug test, I will call the patient in randomly to come in Monday at 9 o'clock in the morning, bring their pills, because I know how many they should have, and ask them to come in randomly for the confirmation urine drug test, as opposed to them doing a drug test when they know it's going to be done.
Michael?
Well, I think, again, I would advocate for expanding the view of the patient and thinking about, has this patient been doing well? Have all previous tests been positive? Is this the very first time you're testing her? What could she really give you as an explanation for this, rather than leap right into, you have to have this test done and you have to do it now, and she is immediately in an argument with you about, I can't afford it, or I can't do it, or why are you accusing me of this after we've been in partnership together for a while. So while I agree with everything that's been said, I think that to facilitate the relationship, in the likelihood that you continue to follow this patient, you're always thinking about, how can I strengthen the relationship rather than undermine it? Because this is likely going to come up again. And presumably, people have been taken through a risk screen prior to initiating the therapy. So you've got some history about, is this a woman who has abused drugs in the past? Is she a smoker and therefore dependent on nicotine? What other risk factors does she have that this sits in? So the context is important.
The absolute key is document your thoughts in the chart. In other words, you looked at the results, you interpret the results, you made action on the results, and you followed through on the action. Whatever you're going to do, whether what Michael says or what you say, the key is document your thought. You don't ignore the tests. And you're using your clinical judgment to make a patient-centered decision of what to do next. We're not here to be police people. We're not here to be the FBI. We're here to be professional medical people to care for our patients. And so document, document, document in your chart your thought process of why you do this or why you do that. And then I think you're protected.
You're not going to find people fault you on doing clinical judgment. As physicians, we do our best. We collect the data, we made
Absolutely.
our best judgment, and we execute it. Nobody's going to fault you on this. What you're going to be faulted on, that when you have data, you do not write. Why did you ask for the data? You do not document what you have done with the data, and then you continue doing something that completely away from the data that you have collected. I think that's
Absolutely.
where the problem happens.
Absolutely.
But as long as you did your best, this is what in the circumstances that you had, you did your best, the interpretation was as such, and you made a clinical judgment at that time, and you move on.
And indeed, I work in a indigent care population where they can't afford all of this urine testing. And I think you're absolutely right. I sit on medical boards and I review cases, and I wouldn't fault the doctor if they said test is negative, patient couldn't afford more medication, and then you make the decision based upon a global view of the patient. She's been on time with her refills, her function is improved, she's doing the best she can. And even if the test is negative, you're making a clinical decision. This is best we can given the information. I want to thank the panel very much for this interesting discussion.